So I'd like to present some of the findings from our prospective study where we looked at the effects of PRP, multi-spot PRP, on both retinal sensitivity and the ability to retain driving visual fields in patients with diabetic retinopathy. Should have checked this out before, shouldn't I? That one. So much of the data I'm going to present this morning has been published now in JAMA, so you can have a look at that at your leisure. So this talk leads on very nicely from the previous talk, where I would still suggest that PRP remains the gold standard treatment for severe non-proliferative disease and proliferative disease. And as we've heard, it may well have a damaging effect on retinal function, given that it is a destructive process. There is some evidence, though, that multi-spot lasers may cause less collateral damage, and many of us are increasingly using multi-spot laser systems. Again, as we've heard, there is really very robust evidence now that there is a role for anti-VEGF agents in the management of proliferative diabetic retinopathy. One of the main caveats I have is that the studies that have been done, Protocol S, the RCRNet, and the Clarity study, did require patients to attend on a monthly basis for 2 years. That's an enormous burden for our patients, and certainly our experience in the UK is that patients with diabetic retinopathy are not always very good regular attenders. So I do have those concerns about anti-VEGF agents. And that's really what led us to do this study looking specifically at retinal function, because that's one of the big reasons people provide that anti-VEGF agents should be used in preference for the potentially destructive PRP. The actual data that exists about retinal sensitivity and retaining driving visual fields in diabetic retinopathy, or both before and after PRP, is really very limited. It's retrospective. It varies from no patients losing the ability to drive to 100% of patients losing the ability to drive with PRP. And so we wanted to assess this in a detailed fashion. So we undertook Humphrey's estimate binocular driving visual fields. We looked at retinal sensitivity, both full field static and kinetic testing using the Octopus 900 system. And we did these assessments both before bilateral PRP and 6 months after laser treatment had commenced. We only enrolled patients who'd not had PRP before. We used the Valon multi-spot laser treatment. All patients had OCT at every single visit. We undertook wide field color fundus photography and fluorescein angiography both at baseline and at 6 months. And the binocular estimates, again done at baseline and 6 months. As I say, we used the Octopus 900 for static and kinetic testing, both at baseline and 6 months. Some concerns about PRP and loss of macular function and the development of macular edema, so we also undertook microperimetry to look at macular sensitivity. And the Moorfields Reading Centre, in a blind fashion, read the colour fundus images to grade the severity of diabetic retinopathy using the ETDRS scale. They also graded peripheral non-perfusion and looked at macular perfusion using various different metrics. They also looked to determine the laser burn coverage, because again, our machine may read 3,000 burns have been delivered, but the retinal uptake gives a very different story. So the eligibility criteria were not controversial, both type 1 and type 2, and that they had not previously received PRP, and that they required PRP in both eyes. So all patients had PRP in both eyes, both at baseline and 2 weeks later, and then they could have further PRP as required every 6 weeks. We aimed to standardize the PRP we actually delivered. There had to be an actual retinal spot size of 400 microns, pulse duration of 20 milliseconds, and we sought to have a 1 burn width separation between burns. Power titrated reaction for each individual patient, so we get a brisk whitening of the retina, and the mean number of laser shots delivered for each patient was in the order of 3,200 burns. I don't think this really, not too much. This is an example of one patient after a PRP and a second patient after a PRP. So if we then look at the baseline characteristics, we enrolled 43 patients, 38 completed follow-up to 6 months. Majority were female, 44% were white. The mean age was 47. As you'd expect, HbA1c was poor at a mean of 9.5. The majority had type 2 and had a duration of diabetes of approximately 16 years. They had the usual comorbidities you would expect, particularly hypertension and hypercholesterolemia. Baseline visual acuities were good, equal between eyes. The majority were patients with proliferative diabetic retinopathy, but we did have a minority who had severe non-proliferative diabetic retinopathy, and at baseline 4 eyes had macular edema. If we then look at the principal outcomes, the disease course in our patients, we found that 31 patients had improvement during those 6 months. 7 patients did not, with 6 of those failing to attend their appointments and had evidence of retinopathy progression and required treatment beyond the 6-month time course. And 1 patient was unable to deliver slit lamp-based PRP and required indirect PRP. If we then look at visual acuity, at exit remained relatively stable, as did mean central macular thickness. There were an additional 3 eyes that developed macular edema during the study. In terms of one of the most important things we're interested in was the ability to retain the UK driving licence based on the preservation of binocular visual fields. So at baseline, before PRP, 95% of these patients actually would pass the driving visual field test. And at 6 months after full PRP, 92% passed. So the vast majority maintained the ability to drive on the basis of visual fields. When we look at static testing, again, there was no significant change, both uniocularly or binocularly. Kinetic visual fields, we did this also to see if there was a disconnect between static or kinetic perimetry. There wasn't. Again, kinetic fields were relatively well maintained at 6 months using all the various isometers we tested. And when we looked at macular sensitivity, again, no significant change during the course of our study. So in conclusion, this is one of the few detailed prospective studies looking at retinal sensitivity both before and after multi-spot PRP. The mean number of shots delivered was 3,200. Visual acuities were maintained over this 6 months. Again, 6 months, relatively short time frame, one could argue. 3 patients developed macular edema during follow-up. We saw significant improvement of disease, with 82% having complete or significant neovascular regression. When we looked at both static and kinetic visual field testing, retinal sensitivities were relatively well preserved during the follow-up, and also when we looked specifically at binocular visual fields, again the ability to hold a UK driving licence was maintained in the vast majority of patients after PRP. And I'd just like to finish acknowledging the funders of this study. Many thanks for your attention.
Thank you, Professor. As we conclude our